Today we're going to talk about fall risk assessment and management, and we're going to do it as a case base. And we have a case of Mrs. Parker we'll kind of get into. So here are the objectives. Hopefully they'll answer the questions from the quiz for you by the time we get through. So we're going to identify what might be appropriate ways of fall risk screening and assessment. Describe ways that we could intervene to allow our older adults to move more safely and avoid fall risk, and list the benefits of promoting fall prevention with our older individuals. So we base a lot of our ECHO on the 4 M's, what matters to the patient: medication, mentation, and mobility. And the last year or so, they've added a 5th M, multiple complexity. And our case today with Mrs. Parker is really going to show how that multi-complexity can really make it a little bit harder for when we have to assess and to do interventions. So importance of the 4 M's is that we're helping to manage healthcare of our elderly individuals and making them safe, making them do what matters for as long as they're able. So when we look at fall risk, this is a real major mobility concern. As a person ages, falls are the leading cause of injury-related deaths in adults that are over the age of 65. There's been a 31% increase in fall deaths. Burns reported in 2018 between that 2007 to the 2016. This is probably due to the increased aging of adults, but we are looking at a fall death every 20 minutes. So this is something that it's very important as healthcare professionals that we look at. It has a huge economic impact, up to $50 billion of medical costs per year associated to fall injuries. And the other thing we need to look at is a fall that a person doesn't get injured in can still impact that person. That could decrease their willingness to want to get up and around, their social interactions, their mobility. Falls can lead to fear of falling, which keeps the person from wanting to go outside or move around as much. And this can be a cycle that is hard to reverse. So fear of falling can lead to that reduced mobility or activity. That can lead to deconditioning, which in turn can increase the risk of falls, can cause a person to fall, and the whole thing starts over again. So the highest risk factor of falling is actually a previous fall. So that's, we're going to see with our assessment, that's one of the big questions we're going to ask is a fall history. So the CDC, the Center of Disease and Control, has a STEADY program, which stands for Stopping Elderly Accidents and Deaths and Injuries. It's a great resource. I would highly recommend to look at it. Everything on there is free for you to download and to use. And so a lot of the stuff we're going to talk about today, you can also find on the CDC STEADY website. So we need to, in order to prevent falls in adults, we need to look at how we're going to start this fall prevention. So this starts with primary care. Clinical fall prevention programs have where we need to screen people. So a screen would be a very quick and efficient way to say, are they at risk or not? So we identify the patients that are at a potential for risk. When we identify those individuals that have a higher risk that for falls, then we can assess them further and decide, can we identify things that we can modify to make their risk less to fall? And then what are effective ways that we can intervene with those clients? And importantly, that we follow up with these individuals that we may have identified as a risk of falling. So our case today is Mrs. Parker. Mrs. Parker, actually the case is on the CDC Steady website. There's 3 different cases. One is for a community active person that has a very low risk of falling. The second one's moderate level. Mrs. Parker has a higher risk of falling, and she is in an assisted facility because she's starting to need some minimal assistance. So she comes to visit with her son for a routine follow-up visit. Her son reports that she has just been seen in the hospital emergency room a week ago because she fell when she was getting out of the shower and hit her head. So one of the things that they're going to do on the follow-up visit is take a medical history. What do you want to know from this medical history? So from the son or Mrs. Parker. So if you guys just want to type in, or if you want to shout out things that you might want to hear about. Medications, how often are you falling? Any changes in medicine recent? Any dizziness? Medical conditions, degenerative diseases or neurological diseases, all great information there. So when we look at Mrs. Parker, we find out her medical history is she does have type 2 diabetes. She has coronary artery disease. She's had MIs in the past, not recently. She's having some problems with atrial fibrillation. She has congested heart failure, hypertension. She has some triglyceride problems, depression, osteoarthritis, the hips and knees. She says she had been doing some exercises, but the arthritis in her hips and knees kind of keeps her from wanting to participate in group exercise. She has some visual changes, old rotator cuff, some sciatica that comes and goes, some fall problems, been diagnosed with osteopenia. She has some GERD if she lays down too flat, and some cognitive disorders that really haven't been diagnosed. So when we talked about the 5th M, I think Mrs. Parker fills in there quite well. A lot of multiple complexity going on with her medical history. What are some concerns you have regarding Mrs. Parker's medical history in relation to her recent falls? Are there things that you might identify that could be risk factors for falling with her medical history? Atrial fib, I would agree. The vision changes. We use our vision a lot, especially as we age. Vision becomes more of a primary resource because we have a decreased amount of sensory, decreased vestibular system. Osteoarthritis, if it slows her down and she's moving less or is more restricted. I would agree with the congested heart failure also. Cognitive issues, because maybe it could be a safety factor. Maybe she's doing things that are creating the falls. So all very good. So if we go on, we might want to do a fall risk screening on this follow-up visit that we had with Mrs. Parker. And so what would be appropriate questions to ask to the screen for fall risk? Some of you have already mentioned the number of falls she has had or falls she had. And then can we identify a self-assessment screening tool you might incorporate into her wellness visit to screen for fall risks? So any other questions you would use for screening of falls that you use in your practice? Somebody asked if she's using an assisted device. That could be one. Show me how you get up. I think that's excellent. So you're looking to see how stable she is to do a functional activity. That would be perfect, Mabel, to do that. what environment? What's her environment? Are there cords? Are there scatter rugs? Does she have handrails? How's the lighting in her assisted living? All excellent ideas. When you do screening for fall risk, a simple way you can do it is doing 3 key questions. A yes response to any of these 3 questions may put the person at increased risk of falling. And if they answer yes, there should be a follow-up assessment to specifically find out what might be causing the fall risk. So those 3 questions are, have you fallen in the past year? And I would follow that up with how often and how did it happen? So this is a yes for Mrs. Parker. Mrs. Parker's son reported in the past year his mother has fallen too many times to count. Mrs. Parker agrees with him. She agrees that she falls a lot, but states old people fall. That's just how it is. So she has fallen, tripping on a rug, losing her balance, turning when she's walking. She fell once rolling out of the bed. She fell at night when getting up to go to the bathroom. And this recent visit, she had fallen getting out of the shower in her bathroom. The second question for screening is, do you feel unsteady when you're standing and walking? And Mrs. Parker reported yes. She reports that she mostly uses a 3-wheeled walker for short distances. She's not been going outside on her own too much, or uses a wheelchair for longer distances in her assistive care. And the third question to ask for screening for fall risk is, are you worried about falling? And this was a definite yes with Mrs. Parker. She states she hardly ever goes outside as she's afraid of falling. So we have that fear of falling, and she is worried about she could possibly break a hip. So self-assessment of fall risk. This was one of your questions on the quiz to start with. The CDC has a Stay Independent Fall Risk checklist on their website. If a person answers 4 or greater of the questions yes, it may indicate a greater risk of falls. If they don't have, if they score less than 4, they're not at a risk, but you still might want to intervene with education in fall prevention, or recommend continue to stay active and mobile with community programs. So this is Mrs. Parker's CDC check your risk of falling. The red arrows show where she checked the yes box. Notice that the top 2 questions, it's kind of small, but I have it bigger on the next slide. If they check yes, they get 2 points, and the rest are 1 points. So looking through the form, Mrs. Parker scored a 9. So that would put her at a greater risk. And this kind of shows what she's put yes for. The steady fall risk checklist asks, have you fallen in the past year? She has multiple times. I have been advised to use a cane or a walker, and she uses a 4-wheeled walker. I'm afraid of falling. Yes. I need to push my hands to stand up from a chair. She does. I have trouble stepping up on a curb. I often have to rush to the toilet, and I take medication to help me sleep or to improve my mood. So the other one, she also said in her previous intake history is, I am unsteady. She feels unsteady when she walks, so she uses that 4-wheeled walker. So she scores a 9 to a 10. She didn't check the I feel unsteady sometimes when I'm walking, but I think she didn't check that because she uses her walker. If she didn't use her walker, she would feel unsteady. So with that little checklist, which you can go through with your clients in a matter of a few minutes, you can identify quickly if they may be at a risk of falling. So she definitely scored much more over for scoring a 9 to a possible 10. So then this would put us over that we should do a more examination. So looking at her physical exam, what should be included in her physical exam during this follow-up visit? What other factors should be assessed regarding Mrs. Parker's fall risk and balance? And thirdly, what might we identify to ease, what is the easy to use standardized assessment we could assess her balance a little bit further? So do you guys have any ideas of different things you would want to, after you did your fall risk screening, different things you would want to look at on her follow-up visit? You just want to throw them in the chat, that would be great. Urgency to use bathroom adds to the risk of falling. Yep. Her shoes, how they fit. That would be good. Is she being treated for macular degeneration? Because that can, that's progressive. So are we dealing with that at all? Pain. So if she has osteoarthritis or osteoarthritis in her hips and knees, and she has pain with standing or ambulation, that could really impact her mobility, start that whole cycle of fear of falling and less mobility. That osteoarthritis, we need to get up and move and lube those joints, or they're just going to get stiffer and sore as we go along. Okay, so if we look ahead to our physical exam of Mrs. Parker, we things that we might want to assess is her regarding fall risk and mobility are listed here, but also to think about, are they modifiable? Are there things that we can do something about, or are they going to be there? So one, we want to early identify any mobility limitations. That's very key, because a lot of times mobility loss is preventable or treatable. So we really want to make sure that we're looking at that. We talked about fall history. Go a step further and ask, how did you fall? I was getting out of the shower. I stepped over the tub. I landed on a slippery surface. Well, then maybe we would look at putting maybe a rug in the bathroom where it's going to be wet. If that's a problem with her getting out of the shower, maybe we modify her to take, have a tub bench and she sits and takes the shower, so she doesn't have to lift over the tub or the lip in a room. Were there shower rails there? Things that kind of goes into the environmental assessment coming up. So knowing the circumstances of the fall, where she fell, when, how she fell, that tells us a lot. And is it modifiable? Was it something in her home that caused the fall? Identify medications. So we're going to look at the medications that Mrs. Parker's on and see if they increase the fall risk at all. The CDC recommends the study program. Vitamin D helps with fall prevention. So assessing her vitamin D intake, might do an environmental assessment by just asking her how her apartment or home is set up. The CDC has some guidelines to do a home check list that you can use. Check vision acuity. Is she using bifocals that might be causing some issues with her moving? Somebody already mentioned checking her footwear. Is she wearing slip-on slippers that don't give her good support? Maybe looking at her postures. There's a lot of comorbidities we already mentioned. Risk of falling, we mentioned cognition. She checking to see if she has orthostatic hypotension. Maybe she's standing up and she's getting dizzy and falling. The depression, I think we mentioned all those. And then we could do some strength, watch her walk, do some mobility tests that we'll talk about. So one primary care quick screen for mobility is to ask 2 questions. For health or physical reasons, do you have difficulty climbing 10 steps or walking a quarter of a mile? Mrs. Parker answers definitely yes. I used to go to exercise class, but stopped about 5 years ago due to my knee pain. She doesn't go outside much because of her fear of falling. Because of underlying health or physical reasons, have you modified the way you climb 10 steps or walk a quarter of a mile? And Mrs. Parker said, yes, I use a four-wheeled walker and she doesn't go out and about as much. So if we see a yes to these quick screens of mobility, that's where we probably want to refer to PTOT to look at those ADL skills and look at her strength and her mobility issues. And looking if she has social supports to help her get out and about if she has mobility issues. So here is Mrs. Parker's medications she takes. She takes 12 different medications during the day. And when you look at the medications, do you have some concerns of these medications she's taking? So the first two are forms of insulin she's taking. The next four are medications she's taking for blood pressure. And then one she's taking for atrial fibrillation. She's taking 2 medications for psychoactive response, Prozac type 1s. And then she's taking cholesterol, and then she's just taking an aspirin as just a small dose of aspirin there. Anything you guys see in those medications you would have concerns about? The amounts of meds, if one of the risk of falls, if people are taking greater than 4 medications, they usually have a higher risk of falling. Looking at the 2 diuretics, the amount, the insulin, diuretics might influence having to go to the bathroom. So the surprising thing is the more medications we have, like I said, the more risk of falls that we have. When you look up the side effects for these medications, you find that 10 of the 12 side effects of the medications is dizziness. Is dizziness a good thing for Mrs. Parker? Probably not. So we look at after Mrs. Parker has her physical exam, we notice that her vitals, they take blood pressure, supine, sitting and standing, because they're looking for orthostatic hypotension. And we notice her blood pressure significantly changes with the change in positioning. So the CDC would highly recommend to check for orthostatic hypotension. We looked at her, the other number is her heart rate. There stays pretty consistent. We noticed that she does have a bruise in the back of her head and swelling in the back of her head from when she hit her head. So we're a little concerned that there's still a resolving contusion. So we know she hit her head pretty hard. So we might be concerned about, is there any new changes in her cognition or memory? We noticed that her posture is a little bit rounded forward. And when she goes to stand, like somebody mentioned, to look at how she stands, she gets a little unbalanced with her first standing. She does wear bifocals. She, with the glass correction, she has 20/30 in the right eye, 20/70 in the left eye. But she reports sometimes her vision gets blurry. And on some of the psychoactive medications can cause blurred vision. She has a regular rate and rhythm of her heart. Lungs look good, GI system's good, but her urinary system, she reports a history of bladder infections. She reports urinary frequency, incontinence, and gets up 4 times at night to go to the bathroom. So these are kind of adding to our fall risk. She does have decreased strength in her lower extremities. She complains of that, especially knee pain. Neurology, nothing to report except she does starting to get some diminished somatosensation in her feet, probably due to her diabetes. Doing the quick psych screening with the PHQ, 2, she gets a 6 out of 6. Cognitive screening, when we do the mini cog, she gets 0 out of 3 items recalled, and she reports feeling blue. So we can see there's some concerns in the results. I kind of pointed them out to you, that the orthostatic hypotension, she got a good knock on the head. She's unstable in her balance, some visual problems, some urinary problems that could hasten her going to the bathroom, causing some fall risk. And definitely the cognitive screen, the 0 out of 3, kind of puts us into some concern. Sorry, I did your homework for you on that one. So her self-assessment, we indicated she scored a 9 or 10, which was way over the fall risk. She reported fear of falling. We talked about the orthostatic blood pressure, taking meds to decrease blood pressure. She has 4 that can impact blood pressure. So is that too much? Is it causing that orthostatic hypotension? We might have the physician review the medication. Does she have to be on that? The visual issues, is that medicine related? Is that her macular degeneration? Is it her bifocals? Has she been to having her vision checked recently? We talked about the bladder issues, the feet. You have decrease in the lower extremities that can impair your mobility and balance. She's taking 2 psychoactive meds. We might want to check if they're being effective. She still is blue. She's still having some cognitive issues. And like I said, 10 out of these 12 meds, if you look them up, they're one of the top side effects is dizziness. So maybe we need the physician to look through, and are these all necessary? The medications, other side effects from the medication she is on can cause confusion, memory deficits, blurred vision, weakness, and hypotension. So right here, we've identified some things that may be modifiable that can help improve that constant falling she's had over the last year. For checking her mobility and fall risk, there's lots of different balance assessments out there, but the CDC did research and they found what would be quick and effective ways to check balance in individuals. And they came up with supporting the timed up and go test, the 30 seconds chair to stand test, and the 4-stage balance test, which is standing with your feet together, standing with one foot halfway in front of the other, doing a tandem stand, and then standing on a single limb stance. So those are the 3 that are recommended by the CDC. I threw in the 10-meter walk test because walking speed is being thought to be the 6th vital sign, and the slower a person walks, the greater risk they would have falling. So I'm not going to take too much time to go over these different assessments, but they're very easy. But I did take time to give you an overview of the purpose, the timed up and go. You have a chair with armrests on, you have the person get up, and when I say go, you time how long it takes them go to a 10-foot line, turn around and come back and sit down. So you start the timing while they're sitting. You say go, you see how long it takes them to stand up, to walk, to turn, and to sit down. Key is if it takes longer than 12 seconds, it's been shown in evidence that the person would be at a greater risk of falling. You can also observe if they're looking like they're unsteady with their walking, and you can give a report of what you observed there. Berry found in 2015 that the tug is probably more useful to rule in falls than to rule out falls. as an assessment. So this is on the CDC website. It shows you exactly how to perform the test, gives you the instructions and a little feedback for your patients. The 30-second chair to stand test is just what it says. Individual sits in a chair without arms, and the standard height of 17 inches. They have to cross their arms for the test, and they have to see how many times they can go from a sit to stand in 30 seconds. There's age norms for this. If they can't stand up without using their arms, they score a 0. You can do the modified 30-second chair stand test and let them use their hands and see how many times they can do it. But the true test is, how many times without their hands? So we'll talk about how Mrs. Parker performs on these. So again, the CDC has the assessment, it has the norms on it, has the instructions for the patients. 4-stage balance test. Start with the feet together. See if they can stand for 10 seconds. Semi-tandem, the heel of one foot is the arch of the other foot. Tandem, one foot in front of the other, and single limb stands. CDC says that a person should be able to stand in the tandem position for 10 seconds. If they can't, they would be at an increase of falling. For Mrs. Parker, she should be able to stand on a single limb for about 5 seconds. So this is showing the 4-stage balance test, how you could score it with the CDC. And then the 10-meter walk test, you just see how many, you score how fast they're able to walk, or you actually do their normal pace walking from one line to the next, and you see meters per second. So if they walk 6 meters, you time how fast they did it, and you can get meters per second. If they walk less than 0.7 meters per second, it would be an indication that the person has decreased mobility and at a higher risk of falling. So this is the 10-meter walk test layout. You usually do 2 meters to warm up walking. You time between line number 2, line number 3. That's 6 meters, and then you have them walk through it so you're not timing them getting up to a normal walk and slowing down. So they have age norms for 10-meter walk test. So when we look at Mrs. Parker's test results, her tug score was 18 seconds. So remember, she was at a risk if she was greater than 12. And she had to use the wheeled walker, and you notice she had a wide base of support walking. 30-second chair stand test, she couldn't stand up without using her arms, so she was a 0. When it was modified and we let her use her arms, she could do 5 in 30 seconds. So that would be way below the average norms to doing without arms. With the 4-stage balance test, she could not stand on one leg. She could not do the tandem stance. She could do the semi-tandem stance for 4 seconds, and she could stand with feet together for 10. So again, she should be able to do a tandem stance for 10 seconds. So she'd be at a risk of fall there. With her 10-meter walk test, she walked at 0.6 meters per second. People that walk under 0.7 are at a higher risk of falls and have a decreased mobility. Some people will even say under 1.0 meters per second to identify the person at a higher risk of falling. So all of these tests, I did your question for you again, I apologize. So identify the test results that would indicate the fall risk of Mrs. Parker. So out of the 4 tests we did, 4 out of 4 indicated her at a high risk of falling. And sometimes we'll do more than just one assessment. Actually, in the study by Lusardi in 2017, found that no single balance test predicted falls. But if you use history questions like we did, use a self-reporting measure that we took from the CDC study program, do the tug and the sit to stand test. There's also another test called the Berg that's a little longer to do, so I didn't include it. They supported that using more than one test was much more effective in looking at risk of falling. So now we've truly identified that Mrs. Parker is at a risk of falling. She clicked all the boxes of put red flags up for us. So now, what might be your recommendations for Mrs. Parker to help her to maintain, improve her mobility and prevent future falls? Or what are some things that you feel that we talked about that may be modifiable for her? So if you want to just add to the chat things that you might recommend for Mrs. Parker at this time. Definitely the medication assessment. I would totally agree on that. That's a lot of medications and a lot of medications that could do it. Maybe refer her to physical therapy for her strength, her osteoarthritis, to get her less fearful of falling, doing some balance activities. Ask the physician maybe to discharge meds that might not be needed. She's 81, she's on quite a few. It's surprising sometimes I find with patients and family members I've had is they get put on a medication, they go to another doctor, get put on another medication, and they might not be that the overlook of all the medications a person's on. Another suggestion from the chat is appointment with primary review of meds, home evaluation for safety. So occupational therapy can do a home eval. I would recommend that she not shower or bathe alone. She's in assisted living, so her a la carte could be having somebody to come in and assist her, especially if that's been more than one of her falls. And so one I would add in here too is the education of the family, the caregivers at the assisted center, and education to the patient of ways that she can prevent falls. So fall prevention recommendations for Mrs. Parker. You guys hit on reevaluating the medications. Or maybe there's some non-pharmaceutical options for some of her symptom management. Implement strategies to address urinary problems, maybe drinking more fluids. There are individuals she can see more about that if she has a lot of bladder infections and dealing with that. Looking at that she's still feeling blue, and that can come with that fear of falling, being less mobile, getting more isolated. Maybe looking at adding vitamin D into her daily medicine just to help. Evidence has shown that it helps to reduce fall risk, and she does have osteopenia also. Educate on ways that she can self-manage her orthostatic hypotension if it's more than just medication related, such as she gets up slowly, doing ankle pumps or hand clenches for a minute prior to standing, not to walk, especially without her walker if she's dizzy. Maybe some of those medications that are causing dizziness, they're taken at night instead of in the morning, but she's getting up 4 times a night, so that might not be that a good of a suggestion, I guess. CDC has a postural hypertension brochure you could give her and the family to go over. Fall prevention strategies, emphasizing those mini falls that she had, kind of evaluating how they could be preventable, if it's the throw rugs, if it's the shower seat, if it's doing the self-management of her orthostatic hypotension. Educate her on how those falls may have occurred. And one of you in the chat mentioned home modification. There's a safety checklist in the CDC on the website that they can go through and look at those. So this is just showing what's available in the Steady Stool Kit, available both to healthcare providers and to the layperson. They have 2 different brochures for each, so things that you can look at. Fall prevention recommendations. You guys mentioned refer to a PT. There's strong evidence that resistance and balance exercises help improve mobility, thus reducing risk of falling. We talked about referring to OT for a home assessment, maybe to an orthopedist about her ongoing knee pain and problems, or to a podiatrist for looking at maybe some shoes. Encouraging activity, maybe in her assisted living exercise programs. It's recommended to get that 150 minutes a week, so 2 to 3 times a week of working in maybe a group that may help her feel less blue and depressed. And also exercising is going to help break that cycle of that fear of falling, decrease mobility. And this can be an exercise program that's a group that she's getting feedback about what she's doing, safety with those, or it could also be that we give her some basic exercises that are safe she could do at home. We mentioned looking at the vision already, and then maybe asking her what matters, what is important to her, what are her goals, and follow up with those. So we get back to our 4 M's. So what are the benefits of encouraging mobility and educating fall prevention to Mrs. Parker? And what are the potential effects of not addressing them? So I think we know the benefits are a lot more. So our big one is to decrease her number of falls, and educating her that older people falling all the time isn't a good thing, and it isn't normal. And if she's fearful of falling to break the hip, that's going to occur more likely as she gets older. So if we work on the benefits, it would increase her confidence, which would increase her mobility and physical activity, increase her strength and flexibility, which all will lead to decreasing her risk of falling, less falls, greater confidence. So we took what we started with and we reversed it to a positive instead of a negative outcome. So research shows that multifactorial fall screening and intervention can reduce falls, not just increasing strength, but increasing strength, education, increased mobility, if we put it all together. So here are some of the benefits of encouraging and promoting mobility in the overpopulation. Evidence shows interventions such as exercises is beneficial. Reduction of medication helps decrease falls and improving home safety. And this was a systematic review done by 2 different individuals. So I won't read through all these, but I think those all kind of make sense to what we talked about. And then I have some references. So I wanted to leave a couple minutes if people had any questions or further comments or suggestions that they might use for Mrs. Parker. I thought she was a good example of somebody that you can see is at a very high risk of falling, and ways that you could work through it there. So any other suggestions or comments?